OCT over here was used basically to define the etiology, that is mechanical or biologic, and based on that we came to a decision as to what to do next, whether it was under expansion, stress fracture, new internal hyperplasia, or new atherosclerosis based on the lesion characteristics. So a 70-year-old patient, she was a diabetic hypertensive, presented with unstable angina. She was on sinus rhythm, was basically presented to us with dynamic ECG changes. She was already, her RICO already had moderate LV dysfunction. It was a case of ischemic cardiomyopathy. She had a history of angioplasty in 2010 to the obtuse marginal and 2015 to the left anterior descending. She was also stented in July 2021. She basically presented to us about 8 to 9 months after after she was stented to the RCA. So the distal RCA was stented with Synergy, and so even the proximal RCA was stented with a Synergy stent. So first off, we did an angiogram which showed that there was occlusive Stent Restenosis in the RCA. It was focal, about 95%, and the stents in the obtuse marginal and the LAD were patent. So now the next plan was, okay, so she was an elderly patient, multiple comorbidities, 70 plus, hemoglobin about 10.5. So she would come under the high bleeding risk category because even her creatinine clearance was approximately 40-45. So she had an ISR for the stent in the RCA. So our strategy first was to predilate. Now the thing was that the catheter could not go inside, so we could not inject the contrast enough to clear the blood. So we thought we'll first predilate. We'll do an imaging, we'll do, that is OCT, and then probably do an adequate lesion preparation. So how we went about this was, we first did a predilatation with a non-compliant balloon. Obviously first we wired it, and then we did a predilatation with a non-compliant balloon, 2x12. And then did an OCT pullback to see how the lesion was. And what we can see here is that there was actually a homogeneous, that is new internal hyperplasia with no focal variation in the back scattering. And yeah, so it showed that the area was approximately 1.83 millimeters square in the middle of the stent at the point where there was about 90% ISR. So what next? So then we already knew the pathology was probably new internal hyperplasia. So and it was probably fibrotic. So our plan was that we first use a cutting balloon, and then because it was focal, we'll probably go with a drug-eluting balloon. And then further on we'll see what happens. So we did another dilatation with a Wolverine 2.75 into 10 millimeters cutting balloon, and then following that we did pre-dilatation again with a 3.5 into 15 mm, and then did an OCT pullback, which showed that there was actually an increase in the area to 5.74 millimeters square, and this OCT also demonstrates it's the cuts caused by the cutting balloon. So there was an increase in diameter from 1.83 to 5.74. Then we used a drug-coated balloon, and we did a POBA to the RCA at 3.5 into 25 millimeters at 12 atmospheres. The final angiogram revealed it was a good result. A TIMI-3 flow, the patient was discharged, is on regular follow-up, and patient has actually come back and is pretty stable now, asymptomatic. So the learning point in this case was that OCT actually helped us to characterize the lesion, and because of which you could use a cutting balloon and a drug-eluting balloon. A drug-eluting balloon would be an effective tool for ISR. It reduced the need for deploying another stent, and the result was satisfactory. And pre-procedure planning was important here with 2 experienced operators. Thank you, sir.